Imagine going in for a routine checkup, right? You get a call a week later, and they tell you your cervical cells look malignant.
Oh, wow. Yeah, that's a terrifying call to get.
Right. And then, after days of sheer panic, you find out it wasn't cancer at all.
Let me guess, it was just a lack of estrogen.
Exactly. It was a lack of estrogen causing a microscopic illusion, basically a biological parlor trick that totally fooled the lab.
Yeah, and honestly, it happens way more often than the medical community likes to advertise.
It's wild. I mean, we're dealing with this diagnostic landscape in women's health that is so murky, even standard tests can totally backfire if they're interpreted through the wrong lens.
Right, because when we look at postmenopausal health, we are looking at an environment where the absence of a single hormone fundamentally alters the cellular architecture. It literally turns standard diagnostic tools into potential liabilities.
Welcome to the Deep Dive. We are so glad you're joining us for this one, because today we're looking at a stack of sources that address a question affecting millions of women, yet it remains shrouded in an astounding amount of clinical confusion.
Yeah, it really does.
We've pulled together clinical guidelines from the American Urological Association, pathology reviews on cervical cytology, extensive studies on the vaginal maturation index, and, diagnostic criteria from the Mayo and Cleveland clinics.
It is a pretty dense collection of literature, I won't lie, but the through line is just vital for you to understand.
So our mission for this deep dive is to answer one highly specific, really crucial question. Can a routine pap smear accurately detect vaginal atrophy, or is a separate, dedicated test absolutely required?
Because relying on a standard pap smear to gauge vaginal health might mean a clinician is, well, they're looking at entirely the wrong anatomical real estate.
Exactly. And looking at the wrong real estate doesn't just result in a misdiagnosis. Like we teased at the top, misinterpreting these tests in an estrogen-depleted environment can lead to some incredibly alarming false diagnoses.
Yeah, it really can. But before we get to the testing mechanics, we kind of have to unpack the cellular reality of what actually happens when systemic estrogen drops.
Right, and the terminology in the literature has actually shifted on this recently.
It has, yeah.
Like the older texts call it vulvovaginal atrophy or atrophic vaginitis.
Yeah.
But the Mayo Clinic and the North American Menopause Society guidelines now officially classify this as genitourinary syndrome of menopause, or GSM.
Right, GSM.
Okay.
And this condition triggers when estrogen levels plummet, whether that's from natural menopause, the postpartum period, or, systemic treatments like chemotherapy and estrogen-blocking drugs.
Because estrogen is essentially the master architect of this specific tissue.
You're right. It really is. In a healthy reproductive state, abundant estrogen keeps the vaginal epithelium thick, it's elastic, it's well lubricated. But when that estrogen withdraws, the tissue doesn't just thin out.
It changes completely.
Exactly. The entire localized ecosystem collapses. Under estrogen's influence, the cells in the vaginal wall produce high amounts of glycogen. And glycogen is essentially the primary food source for lactobacilli, which are the dominant healthy bacteria in the vaginal flora.
So I was reading this, and it sounds almost like the collapse of a rainforest. Like estrogen is the sunlight.
I like that analogy, yeah.
And when the sunlight disappears, the glycogen plants die off, which means the lactobacilli herbivores starve.
Right, they just starve out.
And the downstream effect of that starvation is pretty severe because those lactobacilli are responsible for producing lactic acid. And that lactic acid is what keeps the vaginal pH highly acidic, usually under 4.5.
Exactly. And once the lactobacilli decline, that lactic acid production just halts. So the vaginal pH immediately shifts from an acidic state to a highly alkaline state. It rises past 5.0, sometimes even hitting 6 or 7.
Wow.
Yeah, and that alkaline shift just opens the door for colonization by other bacteria, creating this whole cascade of genitourinary discomfort. The clinical guidelines list the resulting symptoms pretty clearly. Severe dryness, burning, itching, frequent UTIs, and dyspareunia, which is painful sex.
But the clinical data reveals this massive blind spot in how this is handled in practice. Up to 70% of women do not report these symptoms to their healthcare providers.
70%. It's a staggering majority suffering in what's basically a silent epidemic.
It is. Why is that number so high?
Well, there is a pervasive kind of historical assumption among patients that this discomfort is just an inevitable part of aging, right? Like it just must be endured.
Which is so frustrating.
It is. But beyond the social conditioning, the studies highlight a more mechanical issue with relying on patient reporting. The symptoms do not always align with the physical signs observed during an examination.
Okay, so for example, if a patient isn't engaging in penetrative sex, she wouldn't necessarily experience or report dyspareunia.
Exactly. The friction that causes the pain just isn't happening.
So her tissues could be severely atrophied, like completely devoid of elasticity. But because she isn't actively stressing that fragile tissue, the pain remains hidden. Her doctor's symptom questionnaire just comes back completely negative.
Right. The cellular landscape has collapsed, but the patient reporting mechanisms fail to capture it.
But wait, isn't diagnosing vaginal atrophy purely by symptoms kind of like waiting for a car's engine to start smoking before you bother checking the oil?
That is a great way to put it.
I mean, if the dashboard light of symptoms is that unreliable, doesn't that make objective clinical tests absolutely mandatory?
If we connect this to the bigger picture, that discrepancy between the hidden cellular changes and the visible symptoms is exactly why objective tests like the vaginal maturation index were developed in the first place.
Okay, so since objective testing is required, we need to look at the gold standard of measuring vaginal estrogenization, which is the vaginal maturation index, or the VMI.
Yes, the VMI. It's a fascinating test because it actually quantifies estrogen status not just by looking at whether cells are present, but by evaluating their maturity life cycle.
So it's looking at the different stages of the cells.
Right. The VMI evaluates three distinct types of squamous cells: parabasal, intermediate, and superficial.
Got it.
Parabasal cells constitute the deepest layer of the epithelium. They're immature, basically the foundation. Then you have the intermediate cells, which are the transitional middle layer. And finally, the superficial cells are the fully mature, tough cells that make up the protective top layer of a healthy, estrogen-rich vaginal wall.
And the index reads these as a ratio from left to right, right? Like parabasal, then intermediate, then superficial. Exactly, left to right.
So in an environment that's heavily influenced by estrogen, the assembly line is basically running at full capacity. The body pushes those immature parabasal cells through the intermediate stage all the way up to the superficial stage.
That's right. So a healthy premenopausal ratio looks something like 0, 30, 70.
Meaning 0 parabasal cells, 30% intermediate, 70% superficial.
Yes, estrogen is the fuel for that cellular maturation. When systemic estrogen drops, the assembly line halts. The tissue just stops producing intermediate and superficial squamous cells almost entirely.
Okay, let's unpack this. Is it essentially a structural collapse, like a brick wall that loses its top two layers, leaving only the foundation exposed?
Yes, that's exactly what it is. The protective barrier is just gone. You're left with a very thin wall composed almost entirely of those foundational parabasal cells. It tears easily, it bleeds, and it has zero elasticity.
That sounds incredibly painful.
It is. And researchers attempt to define this structural collapse mathematically by converting that ratio into a single maturation value.
How do they calculate that? They multiply the percentage of superficial cells by 1, intermediate cells by 0.5, and parabolic cells by 0. So a higher resulting score indicates a higher estrogenic effect.
But when I was looking at the literature, there's intense disagreement on the actual cutoff for diagnosing atrophy.
Oh, yeah. Huge debate.
Like a clinical review from the University of Amsterdam repository highlighted that Benjamin and Deutsch defined atrophy as a score of less than 40, but then Pinkerton set the cutoff at 50 or less, and Sparoff argued it was 52 or less. Why is there a 12-point spread in diagnosing a literal cellular collapse?
Well, it really comes down to the difficulty of placing a hard mathematical line on a biological gradient. I mean, tissue doesn't just transition from perfectly healthy to completely atrophied overnight.
Right, it's a gradual process.
Exactly. And different decades of research often utilized varying patient populations with different baseline definitions of quality of life. So a researcher in the 1970s might have only categorized the most severe visibly bleeding tissue as clinical atrophy, hence a lower threshold like 40.
Oh, I see.
But later researchers recognized that even mild estrogen deprivation, say a score of 51, causes significant microscopic changes in discomfort, pushing that diagnostic threshold higher. But generally speaking, a score below 49 confirms an environment heavily starved of estrogen.
Okay, wait, I need to stop and clarify something mechanical here.
Sure.
The vaginal maturation index involves taking a swab, collecting exfoliated squamous cells, and examining them under a microscope to count these parabasal cells, right?
Right.
But a routine pap smear also involves taking a swab, collecting squamous cells, and examining them under a microscope.
Yes, it does.
So we're talking about two procedures that look functionally identical to a patient. Why can't a doctor just use the routine pap smear to diagnose vaginal atrophy?
This is probably the most profound misunderstanding in clinical settings regarding GSM, and it all comes down to precise anatomical real estate.
Real estate. Okay.
Right. A standard pap smear targets the cervix to screen for cervical dysplasia and cancer. But the pathology guidelines on non-neoplastic cytology clearly state that an accurate hormonal reading for a VMI requires cells to be scraped from the proximal portion of the upper one-third of the lateral vaginal wall.
Wait. A difference of maybe an inch or two in human anatomy renders the pap smear useless for this?
Completely useless. The squamous epithelium of the cervix and the distal or lower vagina simply do not possess the same density of hormone receptors.
Really?
Yeah, the lateral vaginal wall is highly responsive to hormonal shifts because its primary evolutionary function requires incredible elasticity and rapid structural adaptation. The cervix serves a totally different anatomical function. It's essentially a rigid gatekeeper. Consequently, cervical cells are relatively hormone blind.
Wow.
So examining cervical cells to gauge systemic estrogen levels provides a muted, completely inaccurate cellular picture.
Here's where it gets really interesting. So if a doctor relies solely on a routine cervical pap to check for atrophy, they are quite literally scraping the wrong real estate.
Yes.
But the pathology reviews raise an even darker issue. It's not just that the pap smear is an ineffective tool for measuring atrophy. Using it in this context is actively dangerous.
Right. It introduces a really critical pitfall in diagnostic cytology. Let's revisit the cellular architecture. In a state of severe atrophy, the tissue is dominated by those deep, foundational parabasal cells.
The immature ones.
Right. And because they are immature, parabasal cells possess a very high nucleus to cytoplasm ratio, meaning the nucleus takes up a massive portion of the cell volume.
And to a pathologist looking through a microscope, a high nucleus to cytoplasm ratio is a massive red flag.
It is one of the hallmark indicators of malignancy or high-grade dysplasia. The cells just look hyperactive and abnormal.
Oh my God.
Yeah, the cytology reviews explicitly warn that massive sheets of these estrogen-starved parabasal cells on a cervical smear can actually mimic the appearance of cancer. Atrophic smears are frequently misinterpreted as positive for high-grade lesions in postmenopausal women.
So a patient could receive a false positive for cervical cancer, triggering an onslaught of anxiety, invasive biopsies, specialist visits, all because her tissue was simply starved of estrogen, and the resulting parabasal cells created a microscopic illusion.
Exactly. While a highly skilled pathologist can sometimes identify an atrophic pattern on a standard pap smear, it is never a substitute for a dedicated vaginal maturation index. If a clinician wants to evaluate both cancer risk and estrogen status, they must perform two completely separate scrapes from two completely different anatomical sites during the pelvic exam. One swab for the cervix, one swab for the lateral vaginal wall. They have completely different diagnostic intentions.
Okay, so knowing that the VMI requires this hyperspecific lateral wall scrape to provide an accurate ratio of cellular collapse, does that make it the flawless diagnostic tool we should all be asking for at every gynecological visit?
Well, on paper, the VMI is beautifully objective, but in the messy reality of clinical practice, it carries significant limitations.
Like what?
The cytology guidelines outline pretty intense prerequisites for an accurate VMI. The patient cannot have used any topical or systemic medications recently. There can be zero active inflammation or cytolysis, meaning no concurrent infections like bacterial vaginosis or yeast infections, because those alter the cell structures.
Okay, that's a lot of hurdles.
And furthermore, the patient cannot have had recent sexual intercourse, as seminal fluid or mechanical friction completely skews the cell smear.
Given those hurdles, the lab costs, and the lack of universal consensus on the exact mathematical cutoff, I imagine doctors aren't exactly eager to order this for every patient complaining of dryness.
You'd be right. In everyday clinical practice, the VMI is largely being superseded by blood hormone testing. If a physician needs to confirm estrogen deficiency, drawing blood to check serum estradiol levels is much faster and way less prone to sampling errors.
But wait, blood tests only show systemic levels, right? Not localized tissue health.
Right. Though the VMI remains highly relevant in research. When pharmaceutical companies test new localized estrogen therapies, they use the VMI to secure undeniable microscopic proof that the vaginal tissue is regenerating over time.
So if the VMI is relegated mostly to clinical trials and blood tests don't show the local picture, what is the alternative diagnostic tool for the actual tissue? The sources mentioned the Vaginal Health Index, or VHI.
Yes, the VHI sidesteps the pathology lab entirely. It's a scoring system based purely on the physician's physical examination right there in the room.
How does it work?
The clinician evaluates 5 specific parameters: vaginal moisture, fluid volume, elasticity, pH level, and epithelial integrity. Each parameter receives a score from 1 to 5. A healthy, fully estrogenized environment scores a maximum of 25.
And the diagnostic threshold for atrophy in the VHI is a score dropping below 15, right?
Correct.
And a major component of that score relies on the pH test, which ties directly back to our rainforest analogy from earlier.
Yes. Testing the pH is arguably the most elegant, immediate objective test available. The clinician simply presses a strip of nitrazine paper against the vaginal wall for a few seconds. If the pH reads above 5.0, it is immediate, tangible evidence that the glycogen production has halted and the lactobacilli have been starved out by a lack of estrogen. It's inexpensive, it's instantaneous, and it's highly correlative with cellular atrophy.
Though even the pH test has vulnerabilities, right?
Yeah.
Like active infections like bacterial vaginosis will also artificially raise the pH, which kind of muddies the diagnostic waters once again.
It does, yeah.
Which actually brings me to the most bizarre and fascinating diagnostic experiment in our source stack, the Woods light application.
Oh, the fluorescence study. Yes, it perfectly illustrates how biologically alien this atrophic tissue becomes.
So researchers utilized a Woods light, which emits ultraviolet light, essentially a medical black light, to examine the vaginal mucosa in patients.
Right.
And they discovered that in postmenopausal women suffering from atrophy, the tissue actually fluoresces a pale royal green.
Yeah, the biochemical mechanism behind the fluorescence isn't fully standardized in the diagnostic guidelines yet, but the observational data is just striking. Out of 45 postmenopausal women with confirmed atrophy in that specific study, 36 exhibited vaginal mucosa that glowed pale royal green under the UV light.
That is wild.
And conversely, none of the healthy reproductive age women in the control group showed any fluorescence.
So it provides literal glowing evidence of estrogen depletion.
Exactly.
Now, I highly doubt clinicians will start installing black lights in examination rooms anytime soon, but it underscores just how distinctly the tissue changes at a biochemical level when the hormone is withdrawn. But with all these different tests, the mathematically debated VMI, the VHI scoring system, the pH strips, the UV fluorescence, what is the actual baseline you should expect at your doctor's office?
What's fascinating here is that the researchers and clinical guidelines ultimately synthesized this into a 3-pronged approach. The most accurate, holistic diagnosis of genitourinary syndrome of menopause requires 3 elements.
Okay, what are they?
First, patient-reported symptoms, which is heavily dependent on the clinician fostering an environment where the patient actually feels comfortable disclosing issues like dyspareunia. Second, a simple objective sign, predominantly a pH reading greater than 5.0. And third, direct clinical observation of tissue changes, such as physical pallor, loss of reggae, and diminished elasticity.
So what does this all mean?
Well,
I mean, a routine Pap smear remains an absolute miracle of modern preventative medicine for detecting cervical cancer, but it is emphatically not a reliable standalone test for vaginal atrophy.
not at all.
If a clinician dismisses a patient's symptoms of GSM simply because her recent Pap smear was normal, that clinician is analyzing the wrong cellular real estate.
And if that same clinician panics because the Pap smear shows highly active, suspicious-looking cells, you now understand the microscopic illusion created by parabasal cells in an estrogen-starved environment.
Exactly. If you want cellular proof of localized estrogen status, you require a specific, dedicated lateral wall scrape for a vaginal maturation index. But more practically, you require a clinician who understands the necessity of checking vaginal pH, evaluating the vaginal health index, and bypassing the standard symptom checklist to have an honest conversation about the hidden mechanics of the tissue.
And the structural collapse of that cellular brick wall is not a permanent, inevitable sentence. Localized estrogens and advanced non-hormonal therapies possess the capability to restart the glycogen production, feed the lactobacilli, and rebuild the superficial layers of the epithelium. But, intervention is impossible without deploying the right test in the right anatomical location.
We have spent this entire deep dive analyzing how the withdrawal of a single hormone dictates the entire architectural landscape of a specific tissue. Estrogen literally controls the existence of the top 2 layers of cells in the vaginal wall, regulating its acidity, its flexibility, and its biome. And we really only understand the mechanics of this collapse because we can easily access, scrape, and study that specific anatomical wall.
And that exact realization leaves us with a highly provocative concept to consider. We know estrogen receptors are not isolated to the genitourinary system. They are deeply embedded throughout the human body. They exist in the brain, the cardiovascular system, the skeletal structure, and the blood vessels. So if the transition into menopause triggers a structural cellular collapse, this profound, this mathematically quantifiable in the vaginal epithelium, what other invisible structural collapses are occurring in the deeper, inaccessible tissues of the body? Tissues that modern medicine simply isn't routinely scraping, testing, or illuminating under a microscope. We've spent decades deciphering the exact cellular collapse of one visible biological wall, which really forces us to question the structural integrity of the rest of the underlying architecture.